Hello, welcome to this podcast from the EHA on multiple myeloma. My name is Pieter Sonneveld. I'm a professor of hematology in Rotterdam, the Netherlands, and also the chair of the EHA Scientific Working Group on multiple myeloma. So this is the first one of a series of 3 podcasts funded by EHA, and the goal is to discuss multiple myeloma and its associated treatment, especially in the underserved populations. So these are populations that have specific problems associated with multiple myeloma. The podcast of today will focus on multiple myeloma and renal disease, which is a serious complication of multiple myeloma and that needs to be attended to very carefully. There are other podcasts that you can access and also associated resources. So in order to do that, please visit the EHA Campus, and you can find it at www.ehaweb.org. I would like to welcome Professor Evangelos Terpos, who is an expert in the treatment of multiple myeloma, and especially also for patients that present with renal impairment or patients that develop renal impairment during the treatment and the course of their disease. We speak with Dr. Terpos in his office in the myeloma unit in the University Hospital of Athens, and we are very glad that he made himself available for this podcast. Professor Terpos, can you introduce yourself?
Thank you so much, Pieter. I'm Evangelos Terpos. I'm a professor of hematology in the University of Athens School of Medicine. I'm working in a department of plasma cell dyscrasias. Our department is dedicated in the treatment of myeloma and the more rare plasma cell neoplasms like AL amyloidosis and Waldenstrom's macroglobulinemia. And we have around 150 patients newly diagnosed every year and another 120 treated every day in our outpatient department.
So thank you. So today we will discuss renal disease, and the first question that I would like to ask to you is why is this an important topic?
This is an important topic because we do know that 10 to 20% of the patients present with renal insufficiency at diagnosis, but also till the end of their life or the end of the disease, we may have around 10 to 20% of the patients that may have end-stage renal failure, which creates a lot of problems, not only regarding morbidity, but also affecting the quality of life dramatically, especially for those patients with end-stage renal insufficiency who need hemodialysis. So this is a real problem for the patients, and I believe that as we have the weapons to, let's say, to fight with renal insufficiency from the beginning, we need to do that as soon as possible. We need to be able to recognize it immediately and treat it immediately because we can reverse 50 to 60% of this renal insufficiency in our patients.
Yeah, so you mentioned between 10 and 20% of the patients have renal disease. Is there any difference across ages or other risk groups of multiple myeloma? And what is the cause of it? Why do these patients have renal disease and other patients don't?
So first of all, we have renal impairment because of myeloma and for other reasons outside of myeloma when we see a patient with myeloma. The other reasons have to do with the age of the patients or comorbidities that can happen. For example, hypertension, diabetes mellitus that can create renal impairment because of these diseases. But also the myeloma patients can have the myeloma cast nephropathy, which may create renal insufficiency because of the excretion of the free light chain in the urine. I think that when we talk about more elderly patients, then we can say that the cause of renal impairment is half and half cast nephropathy and other reasons outside of myeloma. But when we talk for younger patients, so below the age of 60, 65, I can say that the cast nephropathy is the most common cause of renal insufficiency in these patients. Hypercalcemia, which is another, let's say, complication of multiple myeloma, as well as other causes like AL amyloidosis or amyloid deposits that can happen in myeloma patients, may deteriorate the renal insufficiency in these patients, infections included.
Is there a clear definition for renal impairment in multiple myeloma? And any international guidelines or advices? Can you comment on that?
Yes, according to the CRAB criteria that we have for the definition of multiple myeloma that needs treatment, the renal impairment is considered as a myeloma-defining event if the creatinine clearance is below 40 ml per minute or the serum creatinine level is above 2 milligram per deciliter because of myeloma. If it is because of myeloma, then we can say that this renal insufficiency is the R criterion of CRAB in order to start treatment. But as I previously mentioned, we have other causes of renal insufficiency, especially in more elderly patients like diabetes, like hypertension that may create renal insufficiency. And we need to be able to differentiate these two categories, myeloma defining event versus a non-myeloma defining event, because you may have a patient with creatinine clearance of 35, for example, and the cause may be hypertension.
Yeah, so we know that often there's discussion in the clinic about the cause of renal impairment in those patients. Do you recommend any diagnostic procedures?
Yeah, I think that first of all, the free light chains in the serum is an important diagnosis in order to know if this if the renal impairment is due to myeloma or due to any other reason. But definitely, we need to know the electrophoresis of a 24-hour urine measurement, where we can see if in the electrophoresis, the protein is albuminuria or non-selective proteinuria, or it is free light chains. If it is free light chains, then we can say that this is because of myeloma and no renal biopsy, for example, is needed. But if we have albuminuria or non-selective proteinuria, then because other problems may happen, not only hypertension or diabetic nephropathy, we may have light chain deposition disease, we may have AL amyloidosis, then we need to exclude these other plasma cell neoplasms. And in order to do that, you may have, of course, a fat biopsy in order to see, or a saliva gland biopsy in order to see if you have amyloidosis. But the preferred method, of course, is the renal biopsy, which is going to tell you exactly what's happening in the kidneys.
So how frequently do you perform a renal biopsy? Some doctors are kind of reluctant to do that. What's the real indication to perform this biopsy?
For me, the real indication is in a patient with myeloma, if the urine test in a 24-hour urine measurement, the electrophoresis, so that we have non-selective proteinuria or albuminuria, then you need to have the renal biopsy in order to know what's happening. If you have free light chains in the electrophoresis of the urine, I believe that you don't need something like that, because the cast nephropathy is the diagnosis that we are going to see with the renal biopsy. So renal biopsy only when we have albuminuria or non-selective proteinuria in 24-hour urine measurement in the electrophoresis of the urine proteins.
Yeah, so now we are talking about diagnosis and monitoring already. What are the challenges of monitoring these patients once they have they are in the clinic or in the outpatient clinic?
I think that we have a lot of challenges in patients with multiple myeloma because the serum free light chain measurement is the gold standard, let's say, for following these patients. But we have also to know that, and of course, the creatinine clearance, that we need to see it improved with treatment. But another entity that I want to mention that we may face, not an entity, but a condition in myeloma, is at the time of relapse, the light chain escape. This happens in our series in around 15% of the patient. What does it mean? That we have a patient with a heavy chain multiple myeloma, IgG kappa, for example, or IgG lambda multiple myeloma. And then at the time of relapse, we have only the light chain that is excreted. And then if we are doing only electrophoresis of the serum, we will not be able to find the progression on time. And if we don't do that, we may end up with a renal impairment, end-stage renal impairment, or patients need dialysis. And in order to prevent that, we need to have the measurement of free light chain also, not only the serum electrophoresis that we are doing in all the tests for myeloma, in order to avoid at the time of progression the free light chain escape that happens in 10 to 15% of the patients. In our series was 15%.
Yeah, so I think this is a very important message, that the serum-free light chain assessments are important in this group of patients, and especially at relapse. The elderly patients were already mentioned by you. Often there's comorbidities like diabetes or hypertension. Is there any specific advice that you would like to give to the people that listen to this podcast? How to deal with the elderly or even the frail patients that present with renal impairment?
I think that the most important issue is to clarify if the renal impairment is due to myeloma or is due to the other comorbidities that the patient has. This is extremely important because if it is due to the other comorbidities, then of course we have to treat the patient according to the guidelines of myeloma and renal impairment, but then the probabilities of reversing this renal impairment is much lower or even zero. So it is very important in order to know what we have to expect for our treatment if the renal impairment is due to myeloma or due to other entities like hypertension or diabetes or any other chronic renal disease. I believe that if we know it, or at least if we know at what percentage the renal impairment is due to myeloma and due to other comorbidities, we will be able to know what we expect from our treatment.
Yeah, so now I would like to move from, let's say, diagnosis and monitoring to what is the real impact of renal impairment on prognosis and on the treatment choices that we can make for these patients. Does it have a real impact on prognosis, is my first question.
It has a real impact on prognosis, and we can see that from the staging of myeloma that includes beta-2 microglobulin. As you do know, beta-2 microglobulin is elevated in patients with renal impairment, and the stage 3 multiple myeloma has beta-2 microglobulin level of more or equal to 5.5, suggesting that these patients or a lot of these patients may have also renal impairment. So from this point of view, we have an indirect evidence that we have a worse prognosis for patients with renal impairment, as the stage of ISS is number 3 in almost all of them. Regarding the true, let's say, the association of creatinine clearance with survival, we have a lot of data suggesting that end-stage renal impairment has lower survival, and especially lower survival within the first 12 months of diagnosis. So if you see the number of patients who die within the first 6 to 12 months after diagnosis, the vast majority belong to patients with renal impairment.
So now we have heard about the dismal impact of renal impairment on prognosis of multiple myeloma, and especially, I think, in the older population. So the next obvious question is, how does it influence our decision making on treatment and the selection of treatment and the goals that we want to achieve? So does it affect treatment eligibility, Professor Terpos, and to what extent?
I think that it is crucial to treat the patients immediately. Hydration is crucial. The ways to remove the free light chain is also extremely important. And the drugs that we use, for example, is also very important. Bortezomib is the, let's say, the cornerstone of the management, of the treatment management of multiple myeloma regarding anti-myeloma drugs. So I think that it is the two messages that we give to the doctors that hear us is, first of all, immediate treatment, hydration, and the anti-myeloma therapy is based on bortezomib-based therapies.
Yeah, so is the goal of the treatment to get a renal response, to restore renal function, or does it go beyond that? I mean, clearly two goals. One is, of course, the renal situation. The other is the treatment of myeloma. Can you comment on that?
Yeah, I think that our goal is to, first of all, to control myeloma, because through to the control of myeloma, we may control also renal disease. This is not always the case. We may control myeloma, but not be able to reverse, especially the end-stage renal insufficiency and especially the hemodialysis recovery and the independence of hemodialysis. However, with the immediate therapy, I believe that approximately 50% of the patients, even on hemodialysis, may become independent of it. And we do have, especially in the younger patients, a lot of cases where the creatinine clearance may become even normal. The International Myeloma Working Group has created criteria also regarding renal response, which is complete, partial, or minimal renal response, according to the creatinine clearance level that someone can achieve with the specific treatment. So, for example, if we manage to have a creatinine clearance of above 50 or 60, then we can say that we have a complete renal response. And this is associated with the response of multiple myeloma. So I think that we need to treat our patients with the best treatment that we can, based on bortezomib, at least for the diagnosis patients with renal insufficiency, in order to be able to reverse the renal impairment and also to reverse the impact, the poor prognosis impact on survival. On the other hand, for patients at relapse, we have never to forget that even if we have managed to reverse the renal impairment at diagnosis, at the time of progression, this may come again and even worse. So we have not to be, let's say, not to feel relaxed if we manage to reverse the renal impairment and to have even complete renal response, because at the time of progression, we may face similar or even worse problem with renal impairment, and we have to be very careful. That's why I suggest the measurement of serum free light chains in every visit of the patient for their workup.
Yeah, so as you said, bortezomib is the cornerstone of the treatment. I have two questions there. Do you prefer single agent treatment with bortezomib or a combination treatment? And my other question is, if the patient responds to this treatment for his myeloma, but the renal situation does not improve, do you switch regimens or any advice?
First of all, we have a very important study of the French myeloma study group by Pieter and colleagues in Journal of Clinical Oncology recently, which showed that if you compare Velcade plus dexamethasone or Velcade plus cyclophosphamide and dexamethasone, the addition of cyclophosphamide could not offer any important, any advantage, let's say, regarding renal response and independence of dialysis. So in your questions, I would say that we can start with Velcade and dexamethasone. In what we have seen is that the high-dose dexamethasone is probably needed for the first cycle of treatment, so the 4 days on, 4 days off that we used to use with the VAD, the very old regimen that many of our doctors that hear us probably don't know. The high-dose dexamethasone is of importance, and we suggest that at least for the first cycle, the patients have to be treated with 4 days on, 4 days off of high-dose dexamethasone. Velcade has to be the standard of care. Possibly the use of thalidomide, if you believe that this is a type of regimen that we use in first-line therapy, may also be of benefit. However, there is no phase 3 study comparing VD with VTD, suggesting that regarding renal recovery, we have better results with the addition of thalidomide. But we do know with the addition of cyclophosphamide, because a lot of people use VCD, this cannot add anything regarding renal recovery.
Okay, and so if a patient is becoming or is refractory to bortezomib-based treatment, either at diagnosis or later on in the disease, what are the alternatives? Usually, according to the general guidelines, ESMO EHA guidelines, we would switch to a regimen based on an IMiD. But how do we deal with this in the renal impaired patients?
At the time of relapse, I believe that for a renal impaired patients, I would not change to an IMiD. I would prefer to go to another proteasome inhibitor like carfilzomib. And we do have data, at least from the combination of carfilzomib with isatuximab, for example. And we are waiting for the results of also of the Candor study for the renal impaired patients with the combination of carfilzomib with daratumumab, of course, always with DEXA. So at the time of relapse, I would not go according to the guidelines for patients with renal impairment in an IMiD-based regimen. I would prefer to change the PI from bortezomib to carfilzomib. I think that we have very good data from the two studies that compares carfilzomib with a monoclonal antibody against CD38 dexamethasone to carfilzomib and dexamethasone alone. And EHA KD, isatuximab KD, or daratumumab KD have shown very good results in patients with renal impairment. The isatuximab KD results have been already published, but the daratumumab KD results also are coming in the next ASH meeting. So I believe that for renal impairment at the time of progression, carfilzomib with the combination of one of the two monoclonal antibodies plus dexamethasone are the preferred regimens.
So last question on treatment. Any pomalidomide combination, can that be used in patients with renal impairment? Because it's often, let's say, third-line therapy in many patients.
I think pomalidomide is a drug that can be used in patients with renal impairment, although we have to be a little bit careful regarding neutropenia and the infections, because although it is not recommended to change the dose according to renal function, we have seen in several patients that the neutropenia and especially infections in renal impaired and especially in end-stage renal impaired patient is much higher compared to what we expected. On the other hand, pomalidomide is a precious anti-myeloma drug that is used third-line therapy as, let's say, the standard plus something else. I would say that, again, the combinations of pomalidomide with one of the two monoclonal antibodies, isatuximab or daratumumab, but even with elotuzumab, has shown very good results in the second or subsequent relapses and renal impairment, of course.
Yeah. Thank you. I would like to switch now to supportive care, and especially two topics that are frequently asked in the clinic. One is about hemodialysis and the use of specific membranes. Can you comment on that?
Yeah, we have now two randomized studies that have been published a few years before. And both studies, I think, have shown that the high cutoff membranes definitely do not impact survival of the patients, which is a very important endpoint. On the other hand, we have publications suggesting that the removal of the free light chains may be of benefit regarding renal recovery. However, the two randomized studies were not conclusive on that. So I would suggest that with the high cutoff membranes, we are not able to confirm better and more rapid recovery of the renal function, and definitely we cannot confirm better survival. That's why we don't use them in our clinical practice here in Greece.
Thank you. And another question frequently asked is about is for patients that do not show renal recovery or response, and those patients are on dialysis for long periods. And then the question arises, is a kidney transplantation possible in those patients? Can it be done? And what are the patients that you would like to select for that?
I think that this is a great question. So we don't have a lot of data regarding that. However, we have some data from the Spanish myeloma study group and others that showed that the kidney transplantation may be an effective alternative for those patients. However, I think that at least in order for myeloma patients to be in a list for a kidney transplant, the patient has to be in complete response. In Greece now they say in MRD negativity, although there are not a lot of data for that, but you understand because of the lack of kidneys for transplant and for the different reasons that a kidney transplantation is needed, the authorities try to put a patient with myeloma into the list only if they are pretty sure that the survival let's say expectancy would be at least of 3 or more years in order to include him or her in the transplant list. So we do have the data suggesting that a kidney transplant is feasible and can offer prolonged survival in some of the patients on dialysis. However, I believe that in several countries, patients with malignancies like myeloma need to have complete response from the malignancy or even MRD negativity regarding myeloma before the authorities decide to put the patient into the list. But of course, this is different from country to country.
Yeah, but I think you are correct that in most countries, at least also in the Netherlands, this is the policy. Also because of the scarcity of organs.
Yeah.
So we are coming to an end of this podcast. Is there anything that you would like to add or give advice on for these patients with renal impairment?
The major points that I want to stress again is first, that we have to be sure that the renal impairment of a patient with myeloma is due to myeloma or not. This is extremely important. And never forget to have the measurement of free light chains in your standard follow-up in order to be able to distinguish the different types of progression, especially the light chain escape. And sometimes also we have even oligosecretory or non-secretory escapes. You have never to forget that, and the measurement of free light chains may help you in finding them on time and avoid renal problems in your patients.
Yeah, so what we discussed is all evidence-based, more or less, and based on a lot of experience in the literature. But now we are in an era where there are many new agents, drugs for myeloma, and also especially immune treatments, including cellular therapies, bispecific antibodies, and so on. We are not going to discuss this, but my question to you is, do you think that patients with renal impairment also qualify for these treatments?
This is a very difficult question because, first of all, I don't have the experience. Second is that the majority of the patients with very low creatinine clearance or end-stage renal disease are not qualified now to participate in the clinical trials that we have with CAR-Ts. And also our experience with, of course, autologous transplantation is that some patients who have also amyloid in their kidneys, if they are not diagnosed before with that, due to albuminuria that the doctors have not managed to capture and the renal biopsy has not been performed, with the autologous transplant, they may have this so-called capillary leakage syndrome, and may create a lot of problems, may die because of the lung problems due to these syndromes and the ARDS. Because the CAR-T cells also creates a lot of inflammation, we need to be very careful, at least for the presence of this type of amyloid deposits, for example, in the vessels of the different organs. But of course, from the kidneys, it's much easier to diagnose. And definitely we need data before suggesting in a patient with end-stage renal failure to have a CAR-T performance.
Well, thank you for this answer. I think in the future we will learn more about it. I think we nicely summarized what the issue is with renal impairment in patients with multiple myeloma and the impact it has on prognosis and on treatment choices. Please, if you are interested, read more in the extensive literature and also the consensus guidelines by the International Myeloma Working Group and EMN and others that may help you further in your patient management. I would like to thank Professor Terpos for his time, his expertise, and also his very clear and helpful explanation of this situation in myeloma patients.
Thank you also, Professor Sonneveld, for the kind invitation to discuss this hot issue, I think, for the treatment of myeloma.
Yeah, thank you. And also, I would like to remind the listener that this is one podcast in a series of 3 on multiple myeloma. The other ones are with other experts, and the topics are the clinical challenges in multiple myeloma for a whole range of situations. And the third one will deal with multiple myeloma in elderly patients and especially in the frail. I thank the listener and the team for their help and their attention, and especially, as I said, Professor Terpos. Thank you.